that we have is a lumbar sacral plexus block patient. So I'll be handing over the mic to Dr. Jasmeet to give a detailed information about the patient. Just that the patient is not a very good patient on clinical grounds. He has multiple comorbidities and an EF finding of 35 to 40%. So
Everyone. So we are starting with the 77-year-old male with left neck of femur fracture, and we will be giving the lumbosacral plexus block. Dr. Sandeep Diwan sir will be giving the block, so he'll demonstrate it now.
Am I audible, Dr. Devesh?
Good morning, sir. You are audible.
Yeah. So I'll just demonstrate the anatomical landmarks first. So this is the highest point of the iliac crest. So we just chalk out the highest point of the iliac crest, and it usually ends at the level of the posterior superior iliac spine. So this would be the posterior superior iliac spine. And the highest point of the iliac crest to the other iliac crest, that would be the intercrestal line. And the line which moves cranial from this PSIS, it intersects at one point, and this is the point of intersection, which would be the point of needle insertion, which would be around 3 to 4 centimeters from the midline, that is the spinous process. Now, if you divide these into the medial 2/3 and lateral 1/3, so if you do that, then you get what is called as the Capdevilas point. So somewhere around at this point, if you insert the needle, this becomes the Capdevilas point, and this is the Venice point. So we've got 2 points, and the Capdevilas point is more closer to the lumbar plexus. That has what has been revealed in literature. So the needle insertion will be perpendicular to the back. It will be through the skin subacute erector spinae. It should hit the transverse process, and once it hits the transverse process, that's the osseous contact beyond which 1.5 to 2 centimeters would be the lumbar plexus, and not beyond that. So minimize it to 1.5 centimeters. If you do not get any contractions of the quadriceps, that's the end point. You have to make a 5 degrees cephalad or 5 degrees caudal needle, or 5 degrees medial or the lateral or medial, and try to locate the lumbar plexus. So this would be in general the flow of the lumbar plexus block. Now the sacral plexus is where the PSIS and the ischial tuberosity. So you'll have to palpate the ischial tuberosity and a line from the ischial tuberosity to the posterior superior iliac spine. Now this would be like, you have to divide this into 3, or can be 6 centimeters from the PSIS. So if it is 6 centimeters from the PSIS, somewhere here would be the needle insertion along this line. And if it is divided into 3 parts, then it would be like somewhere almost very close to that. So this would be the posterior superior 6 centimeters caudal to the posterior superior iliac spine. That's the anatomical landmark. Skin subacute gluteal muscles, you get the contractions. It might hit the iliac bone, and then you have to deviate your needle just to beyond that into the greater sciatic notch to get hold of the sacral plexus. Now for the lumbar plexus, the Shamrock technique with ultrasound. So this is the subcostal again. This is the iliac crest. So in the mid-axillary line, somewhere here in the mid-axillary line, at its midpoint, you need to place the curvilinear probe, and then you have to look at the paravertebral sonar anatomy. So are you getting the ultrasound image?
Yes, sir, we're getting it.
Yeah, so I'm now placing the probe in the mid-axillary line along the line from the subcostal into the iliac crest. इसको this can you हटा सकते क्या? Yeah. So if you look at this, I will just try to locate the structures here in the paravertebral sonar anatomy. So this is the posterior part, the red line drawn, and this is towards me. And from here you can see the articular process, the transverse process, and the vertebral body. So in front of the transverse process will be the psoas major. It's quite hyperechoic. You can see the chordatus lumborum lying on the the top of the psoas major, and this entire will be the erector spinae muscle. And this will be the abdominal muscles. So now this is the view at the transverse process. If you view at this point, somewhere in the posterior medial quadrant, if you divide the psoas major into 4 quadrants, somewhere here will be the lumbar plexus nerve, which usually emerges from the intervertebral foramen. So for this, we have to go in between the intertransverse, in between the transverse processes. So I'm slightly caudal, and you can actually see the intervertebral foramen here. So you can have sometimes the lumbar plexus, which is very nicely visualized. So this is probably the lumbar plexus. This one, which is originating from or emerging from the intervertebral foramen. So that could be probably the lumbar plexus. Please remember, you can see that it is pulsating. It means that the vertebral artery, not the vertebral artery, the lumbar artery is usually placed here. Next will be the lumbar nerve, and your needle is going to be closely positioned to the lateral aspect of the lumbar root. So that's how usually the topography is. Now, if you look at the sacral plexus, so we start at the level of the posterior superior iliac spine. You can see the posterior superior iliac spine, and you can see the glutea muscles. I am going a bit more caudal along the line, what we have drawn a bit cranial to it, and you have to see the brick in the continuity of the iliac bone, which usually is observed at this point. You can now see the discontinuity of the iliac bone, and here would be the other part of the posterior border of ischium and the ilium, and the sacral plexus would generally lie at this point. So this is how you trace for the sacral plexus. A small repetition, going cranial, PSIs, the dorsal part of the iliac crest, the gluteus maximus and the medius, and then you have to see the discontinuity of this. At this point is the discontinuity. A slight caudal tilt will enhance the sacral plexus. So slight caudal tilt will enhance the sacral plexus. So we move ahead with our block technique. This will be a neurostimulation guided block initially. If I am unable to get the contractions, then I will apply ultrasound. So this is a Stimiplex DIG. This is a B. Brown model, and this is used for generating the current, and we usually go for 1 hertz. This is currently at 2.
Can change the preset from shoulder to lumbar or MSK if it's possible. I think that would make the images much more look better. I can see the preset is C15 shoulder on the machine.
So a good eyes doesn't make any difference if it's whatever is the preset.
I agree with you, sir. You have a good eye. Maybe wait.
No, just joking. I agree with you, Devesh. That's the microscopic view of Devesh. Sterling dollar, please. So you'll just immediately paint somebody to assist me.
So any questions up till now? The neurostimulation as well as the ultrasound technique is clear. We are going to use a dual guidance so as to increase. Yes, for lumbar plexus and sacral plexus, always use dual guidance. Yeah, please. Is either the hamstrings or the dorsiflexion and the plantar flexion. Better would be dorsiflexion and plantar flexion. If you are under the effect of muscle relaxants, then you would not get the necessary pictures. Then you have to rely on your own imaging skills in the adults. Let me clarify. With muscle relaxants, you will not get a twitch. Is it clear to everyone? But these blocks are generally done in awake patients for anesthesia. Analgesia, there are so many other options. Why would you like to go for advanced level blocks for analgesia? Is it clear? Any questions up till now? Is the concept clear of the Capdevilla's point, Vinny's point till the time they appear? Sir, over to you.
Yeah. So I've already infiltrated lignocaine, though the patient will not require, but because the patient is being anesthetized with remifentanil, already IGL has been inserted and no muscle relaxants, of course, and there's some sevoflurane going on. So we're just connecting the peripheral nerve stimulator. So initially we'll go with the landmark technique, and if we don't get the contractions, then we go ahead with the. So this is the Pajung needle. It's a hyperechoic needle. I call it as a hyperechoic needle. This is a nanoline. This is inserted at the Capdevilla's point. It's a bit blunt needle. So you have to progress very slowly, advance very slowly, try to counter the transverse process. Sometimes you walk into the lumbar plexus. That is a possibility. Yeah, so can you just, yeah. So can you see contractions of the abdominal muscles? If somebody can point out the contractions of the abdominal muscles, it means that the needle is going in the anterior thoracolumbar fascia. It's stimulating the ilioinguinal and iliohypogastric nerves. You can very well do a anterior chordatus lumborum block with some amount of local anesthetic technique. It means that my needle has to go a bit more caudal. So I'm caudal in the sense it has to go medial, sorry. So slightly repositioning that and going a bit more medial. So I'm unable to hit the transverse process. Going a bit more medial. I could hit the transverse process. So I'm keeping my needle just around 1.5 centimeters beyond that and not going still more caudal, medial. So this will be a caudal and medial again. The Capdevilla's approach is actually closer to the lumbar plexus. Now this can be, sometimes the lumbar plexus, it falls totally on the lumbar vertebral body. If it's geriatric patients, you have got atrophic psoas major, and that's why you don't get those visible contractions, because the lumbar plexus falls away from the approaching needle. Increase the current, please. Yeah, that should be fine. One should be fine. So this probably the transverse process. I am keeping around 2 centimeters. I am going cephalad.
Yes. We are able to see the twitches.
Yes. So these are the contractions. So I will ask him to reduce the current to 0.87. Still more. Don't pull out the needle. Huh? Still more. Lower down. Still more. It is probably intraneural, because I can see the type of contractions which are quite. You can still more go down. Yes. Can you see that it's 0.2, and you can still get the contractions. So I'm just going to apply probe and let's see where our needle is. So you can usko band karo shishir.
Contractions at 0.2 milliamperes.
Yes. So
we are in. So we'll withdraw the needle.
Yeah, we withdraw, but I will place the probe first and assess where exactly our needle would be.
Now, can we have the ultrasound image also? Yeah, we are seeing the ultrasound image, sir. Yes.
So, Devesh, your presets are fine now?
Yes, sir. So we can see the needle.
Yeah, you can see the needle here. So this is the needle. Got it? And this
Yes,
is
okay.
probably the this is probably the lumbar plexus.
Yes, sir.
That's the vertebral
Here it-
body. Yeah. So now what happens is, as you rightly pointed out, we require the withdrawal of this needle. So I'm just trying to jiggle it. Yeah. So probably it's very close also to the intervertebral foramen, and I think there could be some epidural spread. This is the needle. Okay, can you increase the current?
So everyone can appreciate the needle.
Yeah. Yeah, so now you're getting at 0.76. Okay?
sir.
Yeah. So now what I do is, I will now going to inject local, always aspirate, as it's a very high and vascular structure. And I'm going to slowly inject local here at this point.
Can everybody appreciate the injection of local anesthetic happening? Yeah.
And you can see that lumbar plexus, it's floating now, that hyperechoic thing right in the middle.
Yes, we can appreciate, sir.
Yes, so for those who may not be able to understand, this is the lumbar plexus in the middle, and that is the local anesthetic which is going around. Got it? So I'm going to inject around 20 ml, 0.375 ropin. So this is the volume of local anesthetic which is injected. So I inject around 10 ml here at this point. You can see how it now delineates the lumbar plexus. Okay, now what I'm going to do is, I'm going to make this longitudinal, keeping the lumbar plexus in view. They will just point out the hyperechoic thing and the hypoechoic thing to the audience, and this I'm making it longitudinal.
Yeah.
So what we are trying to see is the longitudinal spread of the drug and the lumbar plexus. So this is the longitudinal lumbar plexus. And I'm going to inject local now. And you can see a similar spread going along the lumbar plexus. Can you see those spread?
Yes.
इसको सेव कर सकते हैं क्या?
So this is happening in the posteromedial quadrant, as we
It-
said it is located.
Yes, posterior, because the anterior, what you see on the top of the entire hypoechoic is all the lumbar plexus, and along with the local anesthetic and the psoas major above it. And below will be a thin strip, as I said rightly. Gloves निकालो. Gloves. नहीं, ये gloves निकालो. So what exactly is, this is the entire the vertebral body. This entire the vertebral body. This is a thin part of the psoas major muscle. This is the lumbar plexus. That is the local anesthetic which is going around, and this is again the psoas major. And on the top of it would be the erector spinae muscles. So this is how it's placed in the coronal oblique view, what we call it as a coronal oblique. That's the lumbar plexus. Now we can entirely see the lumbar plexus here. This all is the lumbar plexus. Okay, did you get it? I'm going to remove the needle now because we have injected the entire volume of local, and we go for the sacral plexus. So the needle length. So the needle length is like 1, 2, 3, 4, 5, 6, and 7. So it's around 7 centimeters. Gloves, please.
So any questions up till now on lumbar plexus? Is it clear? So right now they have injected 20 ml of 0.375%.
Yes.
Sir, had it been an anesthetic block, what would be the concentration?
So 0.375 is good enough, Devesh. We usually use around 0.33. But now this patient also has a component of CKD with serum creat of 1.5. So we thought of decreasing the concentration and the volume as well. If appropriately placed, 0.4 ml per kg body weight of local anesthetic is fine enough. 0.375 ropin is what we use nowadays. We used to use 0.5% bupivacaine and 1.5% xalocaine. So we inject local anesthetic. So somewhere along this point would be the needle insertion. So I'm just giving a local here, and we progress with the needle placement. Again, the current, please, can somebody just make the current a bit more, around 1 milliamperes. इसको यहाँ पे रखो. Yes. I need to see that. Yeah. So we are through the skin subcute. You can anticipate gluteal contractions if I'm in the right path. So it's already that seems to I've hit the bone. So I have to see that I don't go beyond that, 2 centimeters beyond that. These are deep blocks, and I think you have explained that this is not to be done in anticoagulated patients, patients who have got coagulopathy. A bit more caudal. And if you're not getting it, you have to reassess your anatomical landmarks. So probably you have not palpated the posterior superior iliac spine or the ischial tuberosity. More commonly, it is the ischial tuberosity which creates a problem. So just I'm changing the position of the needle insertion. Sacral plexus is known for, and lumbar plexus is known for multiple needle redirections, as well as less tolerant by the awake patients. So you cannot go too deep as well, because you have the beyond the sacral plexus would be the viscera and the those neurovascular structures. So you have to be very careful when you needle the sacral plexus. I think this would be beyond this. I should not go beyond this. So I've held it 2 centimeters after hitting the bone. Okay. Can you see the contractions?
Yes, we can appreciate.
Yeah. So what I did was I just slid the needle just beyond when I had hit the bone, probably a part of the greater Shattuck notch. You can see that there is inversion or eversion. So you got the hamstrings, but you got the foot also. See, now you get just the hamstring. You get just the gluteal contractions. And when I repose the needle, then you get the contractions of the calf muscle. I'm going to go a bit more inside, and now you can see the contractions of the toes. Can you see the contractions of the toes, Devesh?
Yes, sir, we can appreciate.
Yes, so that's the plantar flexion with contractions of the toes. So
Inversion.
I'm going to decrease the current now. Now decreasing the current at 0.8 I can still reduce it. Just want to exclude intraneural. Yeah, that should be fine. So at 0.4, that's we still have the contractions. Yes. वो दिख रहा है क्या वहाँ पे? वो दिखाओ. इसको no, ये वो दिखाओ. No, ये दिखाना चाहिए. The toes.
Yes, we can still appreciate subtle contractions are there.
हाँ. Can you see the great toe? Yeah. So yeah. So I'm going to now inject local. So you have to always again aspirate. You have got inferior gluteal artery, superior gluteal artery. Just I'm having a bit of resistance. So probably I have to just withdraw.
Can the camera person focus on the injection part?
Yeah. I'm having some problem with this. So probably the needle also would have been blocked. Yes, this has come out of the block. Now there's a free flow of the local. You don't get any contractions anymore because of the ionic gradients. So again, you have to aspirate, keep on aspirating and injecting local. So sometimes you get gluteal contractions prior to reaching the sacral plexus because that's encountering the inferior gluteal nerve, which innervates the gluteus maximus, and that's the gateway to the sacral plexus. The moment you get gluteal contractions, the next would be the sacral plexus. So that we have already published, gateway towards sacral plexus. So I thank. The drug is again 0.375 ropin. So we don't require much volume. This is basically a supplemental block. So around maybe 10 ml should suffice in this area. So I will just see the immediate a fast scan of the parasacral, and then we go on to the next block. So just keeping the probe, this could be the like an out of plane. I'm not sure whether we'll be able to see the needle. You don't see the needle as good as it is, but you can see the sacral plexus. So the sacral plexus is lying here. Yeah, isko karo.
Can you point out with your red marker? So
Yes,
that
yes,
I
yes,
can
yes.
show that
Yes, he is marking.
This is the second.
That's the sacral plexus. You can see that it's almost like it's dividing at this point into two structures. So probably there's a high division of anterior and the the tibial and the peroneal components. So I'm just going to remove the needle. You may be visualizing. You can see the needle. I'm just jiggling that needle and I'm going to remove that. Going to withdraw this, so it's right inside the sacral plexus, not inside but around the sacral plexus. So I'm just trying to scan the way we had scanned earlier. So again, for the last time, this is the that's the posterior superior spine, and we are coming more caudal, and we will see a break in the bone. That break in the bone is where the sacral plexus lies. And if you can freeze that, I will show them. Can you freeze that? Yes. So you can remove him. So I thank the entire team here for a patient who is very complicated but very well managed by everyone. Dr. Shipra, she is the one who is managing this case. So this entire is the sacral plexus. This is the local anesthetic which goes around, and usually it emerges this way, and then it forms the sciatic nerve. So thank you very much, Divesh. We are done with this case. If you have any questions, we can answer, or you can go ahead with your scanning session. Or
So any questions on lumbar plexus?